all the people that are here. And I know that some people are together, so just have everybody that's here send you confirmation that they're here. Okay? So I'm a little bit concerning that we have so few people. All right, so can you guys see my screen? I can't see you guys. If you guys can turn on your videos, it would be great, because I'm talking into to nothing. Please, everybody, turn on your videos. Can you guys see the screen? Can someone nod their head, yes or no? Yeah, okay, Paula can see.
I can see a screen, yes.
All right. So those of you that listened to these talks in the past year will see that the anatomy didn't change much. What we're going to do in the next 3 weeks is go over the upper and lower limb examination and some pearls that I think you need to know. Hopefully by now you all have the booklet, the aids to the exam of the peripheral nervous system. Those of you who are PGY 1s and 2s, should, if you didn't get it yet, should pick your copy from Marjorie. And hopefully the 3rd and 4th years already have theirs. If not, let me know. So what we're going to do in the next 3 weeks, we're going to divide it. The next 2 weeks are going to be upper limb. And the 3rd week is going to be lower limb. Today, we're going to talk about the brachial plexus. And next week, we're going to talk about individual nerves of the upper limb. If there's any question, please unmute yourself and just barge in and ask. Please keep your videos on, okay? I want to see who I'm talking to. All right. Okay, so let's start. Let's see if this works. All right, so first nomenclature. So this is something that sometimes people forget, is how the roots are named. The roots in the cervical spine are named. Can you guys see the mouse? I hope you guys can see. The nerves are named corresponding to the vertebra below them. So each nerve is above the corresponding vertebra. So C1 comes above, C1 root comes above C1 vertebra, C2 above C2, and so forth until we get to C8. Obviously, you remember that mammals, whether you're a whale or a giraffe or a gorilla, it doesn't matter. There are only 7 vertebrae. So C8 comes above T1, right? What this means is that from T1 downward, the root always comes below the corresponding vertebra. And this will come up when we talk, not next week, but the week afterwards, about the roots in the lower spine. So don't get confused about that. Just remember, in the upper part of the cervical spine, the roots come above. In the lower part of the cervical spine, the roots come below. So that's how you'll never forget this. Okay. Now, as far as the brachial plexus, now I know that this is something that no one likes to learn, but it's actually very easy. But what I would recommend is to learn it the way we're going to go over now, which is kind of to break it down and to break it down in terms of movements, structure and movements, rather than the kind of ways of short-term recall of drawing a fishbone kind of structure that you'll see in YouTube. If you just Google how to learn the brachial plexus in 5 minutes, that means you'll never learn it. I mean, it will go in one ear and go out the other ear. And also, it's not going to be useful to you in terms of examination of patients. Ultimately, the reason to know it is because we need it for our patients. So what I would recommend is when we go over, you'll see in a moment, that the nerves have function. So remember things by their function and associate them with the examination of the patient. And that's how you'll remember things. And also it will be easier for you to localize eventually. You'll get used to, and you'll be able to localize, so you won't say the patient has hand weakness, just like a non-neurologist. I want you to say the patient has a musculocutaneous neuropathy and so forth. So in order to say that, you need to actually go through the function of the nerves and the muscles innervated by them. So the brachial plexus is mostly involved in stabilization and movement of the shoulder. We'll show one muscle that is associated with elbow flexion later on, but most of the brachial plexus is associated with the shoulder movements. So we'll go over the various movements, and basically you need to remember what abducts our arm, adducts our arm, flexes, extends, internally rotate, and externally rotate. I hope you can see the video of me. I could, if you want me to, stop sharing so you'll see a bigger me, but that would be probably wasteful. But let me know if you prefer that. But otherwise, you'll have to look both at my slides and at my motions. It's a little bit strange to give a talk like this, but that's the way it is. All right, so brachial plexus. There are many ways of remembering the structures of the brachial plexus. There are many mnemonics. Probably one of the most famous one is Randy Travis drinks cold beer. So what does that mean? So in terms of the kind of basic structure of the plexus, we have our roots here. We have the 5 roots, the C5, C6, C7, C8, and T1. Okay, those are our roots. Okay. So that's the Randy. And then we have the Travis, the trunks. So the upper 2 and the lower 2 combine to become trunks. So the upper 2 combine to become the upper trunk, C5 and C6. C7 continues on its own as the middle trunk. And C8 and T1 combine to become the lower trunk, okay? But there's not much action here. You need to know these structures, but there's not much action here, okay? But there's a lot of potential pathology in this location. So processes that compress from above, the upper trunk will give classic presentations, and processes that compress from below, but can give classic presentations. But in terms of nerves that come off, there's not a lot of action here. The next thing that happens is each trunk divides. We have divisions, right? Divisions, drinks, divisions, divides into anterior and posterior divisions, each one of them, okay? So the upper trunk divides into an anterior and posterior. The middle trunk divides into anterior and posterior, and the lower divides as well to anterior and posterior. And all the posterior divisions from each one of them, all of them combine together to become the posterior cord, okay? So we're already jumping from the divisions to the cords. And the way it happened is because of this division to anterior and posterior, each trunk contributed a posterior division in order to establish the posterior cord, okay? And it's named posterior because it's behind the axillary artery, okay? So imagine that the axillary artery runs here, so it's behind the axillary artery. Right? Which leaves us with the other 2 cords. In this case, we have the lateral cord, which is a continuation of the upper trunk, and the medial cord, which is a continuation of the lower trunk. Now, don't let this fool you. The upper trunk and the lower trunk, you know, this is the area here, it's really above and below. But once we get to the limb, we really talk about what is lateral and medial. So everything is going to be divided into lateral and medial. And then we have the posterior behind, okay? So the medial and lateral correspond to the limb itself. And that's why we switched from calling the trunks upper and lower, and then the cords lateral and medial, okay? All right, so that's the structures until the cords divide into the branches, in other words, the nerves themselves. The nerves themselves, as we mentioned earlier, we're going to talk about them in the next noon conference. All right, so let's go back to the brachial plexus and see what's going on. And first, let's start with the first part, with the roots part. So in the roots part, there are two important nerves that you need to remember, okay? In the roots area, there are two important nerves you need to remember. The first one is a nerve that has its origin from the three upper roots of the brachial plexus, C5, C6, C7. Together, they become the long thoracic nerve, okay? Now, the long thoracic nerve innervates, as you know, the serratus anterior. So, what is the serratus anterior? The serratus anterior is one of the muscles that is responsible for movements of the scapula. If you think about it, what allows us to have this huge range of motion in all these directions is because we have the movement of the scapula. So the scapula, when it moves upwards, the glenoid fossa here allows the humerus to go in a very steep angle, which it wouldn't be able to do that if there wouldn't be movement of the scapula. So the scapula has to be able to move. It's a bone on its own, but if you think about it, it's not connected to anything. It just lies around and has to be able to move to allow us all this range of motion. So in order for it not to fly around, we have to stick it to the rib cage and also control the movements. So there are three important muscles that you need to know that if they are weakened, then the scapula will move from its location or have a change in its location. The terminology that we use it clinically is winging, because when the scapula is not attached to the rib cage, it wings. It becomes like wings, okay? Now, everybody knows that the serratus anterior weakness causes winging. But on your boards, and please remember this, money back guarantee, on your boards, you are not going to be asked about the serratus anterior. That's a UCMLE step 1 type of question. You're going to be asked, what are the other muscles and nerves that are responsible? And you have to remember that there are three, okay? One of them is not related to what we're talking about. It's the trapezius. The reason that it's not related, as you remember, the trapezius is not innervated by the brachial plexus. It's the spinal accessory nerve, right? But even though it's not a brachial plexus, it's still relevant to our discussion here because it's a major stabilizer of the scapula. So if we have weakness of the trapezius, for example, if there's trauma, if there's a gunshot wound or laceration or surgery, that's not an uncommon problem. If you have some sort of cervical surgery, the spinal accessory nerve can be severed and we'll have weakness of the trapezius and winging of the scapula. So the scapula will appear detached. So again, it's not a lesion of the brachial plexus, but it's a classic cause of winging of the scapula, which you need to remember. So please do remember that, okay? So that's number one. Now, another kind of general cause of winging of the scapula, which is not an individual muscle, is when we have weakness, which is general. So if we have a problem that is part of what's called limb girdle weakness, and there's actually, as you know, a group of disorders. I don't know if you already had this talk about myopathies. The limb girdle dystrophies, their kind of hallmark is this proximal weakness in the limb girdle. One of the classic causes of weakness in this area is in the FSH disease, facioscapulohumeral disease. So it's not an individual nerve, not an individual muscle. It's just the whole area here is weak. And again, that will cause detachment of the scapula and winging of the scapula. But what we're talking about now, the three individual muscles, is not this general weakness, but rather a specific cause of scapular winging. So we already mentioned the trapezius, and we mentioned the serratus anterior. In a couple of minutes, we'll talk about the third stabilizer of the scapula. But before we do that, there is a concept that you have to learn, and that is whether the scapula wings medially or laterally. Okay, so now let's see if you guys are listening and concentrated. If we have weakness of the serratus anterior here, look at the picture here, all right, which is attached laterally. It fixes laterally the scapula. If someone undergoes surgery or trauma and their long thoracic nerve is cut, and they have now a specific weakness of the serratus anterior, what type of weakness, what type of winging of the scapula will you have? Lateral or medial winging of the scapula? This is a board question. What do you guys think?
Medially.
Sorry?
Medially.
Medially. Who said it?
Stroke team.
Stroke team. Okay, so stroke team gets 2 points, right? So if you think about it, you see the cursor here? If we have weakness here, then whatever is pulling from the medial part of the scapula will overcome, right? So there's a tug of war. The medial muscles are pulling this way. The lateral muscles are pulling that way. The serratus anterior is a lateral muscle. If it's weak, then the scapula will move that way, right? So it's going to be medial winging of the scapula. Okay, medial winging of the scapula, serratus anterior. Okay, and because I'm emphasizing this, in a moment you'll see the opposite of this. Okay. Right, so that brings us to the second nerve that comes off this root region. This is the dorsal scapular nerve, and it comes from C5. We as EMGers love this type of situation because the way we're constructed, usually nerves have more than one contribution. Okay, so the median nerve, for example, is an example. Every single root contributes to the median nerve. We'll see in a moment, pectoralis muscle. Every single nerve, every single root contributes to the pectoralis muscle. So in terms of localization, it makes life harder. But when we have a muscle that is innervated by a single root, if we have isolated pathology in that muscle, that tells us that there is pathology, isolated pathology in that root. So there's not a lot of examples like that. So that's why we as EMGers love these types of situations. So what is the muscle that is innervated by dorsal scapular? It's the rhomboids, okay? So remember, we talked about stabilization of the scapula in the lateral aspect, which was the serratus anterior. Now we're talking about stabilization and movement of the medial aspect of the scapula. So that's responsible for movement of the scapula by pulling in direction of the angle in the back, okay, in the dorsal. That's done by the rhomboids. We have the minor and the major. That's not important to you, but what is important for those of you who are budding EMGers in the future is that if you're interested to identify if there's a C5 lesion, then you can take a needle and poke it. You need to make sure that it's not to the trapezius, so you have to go deep enough, not too deep in, to cause a pneumothorax, but you go deep enough to assess the rhomboids. And if you have signs of denervation there, you probably, I don't know if you already had the talk about EMG, but if you have fibrillation potential, as a positive sharp waves and so forth, that tells you that the C5 root is involved. So if we have weakness of the rhomboids, what type of scapular winging will we get? And the menu of the day is lateral or medial. So,
Lateral.
Oh.
It's lateral.
Sounds like it's
was
not.
it a hot?
Yes.
Excellent.
No.
So again,
All right.
we have
That's all our recommendations.
this
Treat
tug
the
of
infection.
war where we have the meat, so the scapula, think of my head as the scapula, okay? And we have the medial muscles and the lateral muscles, the serratus anterior. In this case, we have weakness here. So let's say we have a C5 lesion. Then in the tug of war, my head will go laterally, okay? Because the serratus anterior in this case is strong, okay? So then we have the lateral scapular winging. Obviously, if we have avulsions of all the upper roots of the brachial plexus, we'll have generalized weakness, and it will look like FSH weakness, and then we'll have just the floating of the scapula. But that's not common. Okay. Let me know if there's any questions. But those are important things, not just clinically, but also for your boards. The next, so now until now we talked about stabilization of the scapula. Now we're diving into movements of the shoulder. Remember I told you, remember things by their movements, okay? So the two movements that we're gonna talk about now is abduction and external rotation. Okay? I don't know if you guys can see me. External rotation. You see my wrist is going outwards. Okay? External rotation. And the other movement is abduction. Okay? In this case, we're talking about the beginning of abduction, up to 30 degrees from the body. Okay? Those are the two movements that we're interested in now. And the nerve that is responsible for that is the suprascapular nerve, okay? Suprascapular nerve. And that nerve comes from the upper trunk. This is very, very important because, as I told you, this area is susceptible for pressure. Hikers, or in the past, I was in the Army, and there were people who you know, hike for tens of all night or for days with backpacks that weighed, let's say, 50 kilograms on their shoulders. Eventually, some of them developed weakness that was associated by pressure on the upper trunk. And the specific weakness that they had to do with weakness of the suprascapular innervated muscles, all right? So what are they, and what did we see in those backpackers? Okay, so the suprascapular nerve actually has proximal branches and distal branches. Okay? And that's important to know because the proximal branches branch first and innervate the muscle here. That we'll show the muscle in a moment, but I just want to make sure we get this concept. And then we have the distal branches that go underneath the spinal glenoid ligament here inside the glenoid cavity. Okay? And then they reach the muscle here, the lower muscle. Now, this is important because this area here in the glenoid cavity is susceptible to trauma or to lesions in the glenoid cavity. So for example, if there's a motorcycle accident where there's crushing of the humerus into the humeral head, into the glenoid cavity, you can get a lesion of the distal part of the suprascapular nerve while the proximal branches remain intact. So then we'll have weakness of the muscles here, the lower muscles, and the muscles up here will be intact. All right, so now let's explain what we're talking about. So the muscles on the top, the muscle on the top that's innervated by the proximal branches of the suprascapular nerve, that muscle is the supraspinatus muscle, the supraspinatus muscle. Now, the action of the muscle on the humerus is determined by where it's inserted. And look here, it's inserted in the upper lateral aspect of the humeral head. So when it contracts, it will pull the humeral head inward medially, okay? And when that happens, we have the arm go outside. Outside is abduct, away from the body. Abduction, away from the body. And this is important because once that happens, a stronger muscle can take over and do the rest of the movement. We'll get to that muscle in a moment. But it's important to remember that this abduction is done by the supraspinatus muscle, and that is innervated by the proximal branches of the suprascapular nerve. Okay? Now that is different from the lower part here, which it's the infraspinatus muscle. You see here, there's another muscle here, which is a teres minor. The teres minor is not innervated by the suprascapular nerve. We'll get back to the teres minor. It's innervated by a different nerve from a different part of the brachial plexus. So there's a little bit of redundancy. But what's important is that the muscle here, the infraspinatus, is innervated by the distal part of the suprascapular nerve. Now, again, the insertion on the humeral head determines the movement. If you see here closely, if you see my cursor here, it's attached in the posterior lateral aspect of the humeral head. So when it contracts, we get pulling of the humeral head in a rotation movement that causes the arm to go outside. External rotation. Okay. So if we have a lesion in the upper trunk causing a lesion of the suprascapular nerve, the patient will have weakness in the beginning of abduction and external rotation. Okay. But if the patient has an isolated distal suprascapular lesion, then they'll only have the difficulty with the external rotation. With a little bit of redundancy, there's a small here component that maintains a little bit of the function. It's not going to be completely paralyzed, but most of it, yes. Okay. Please let me know if there's any questions. This is kind of important. This is important in terms of the examination of the patient, but also obviously for tests. So we talked about two movements so far of the shoulder. Now we have a major muscle that controls the shoulder, and that's the pectoralis muscle. The pectoralis muscle really connects the shoulder to our body. That's kind of one of them. If I don't know, you won't find it maybe in books, but that's really it connects the shoulder, the humerus to our body. It also moves the arm. The main movement is adduction and also flexion. Okay, that's the pectoralis. The pectoralis has multiple components. We don't need to get into that, but it's what we use when we do push-ups, for example. As you know, it's a very large muscle here. Now, the problem with the pectoralis is that if you look at the innervation, it's innervated by branches that come off the lateral cord and the medial cord here. So both of them connect to one nerve. Now, what does that mean to us? If you look at the contributory roots to the lateral cord and medial cord, you'll actually see that it comprises all of the roots, right? So the pectoralis muscle is actually innervated potentially by all of the roots, okay? It's true that the upper part of the pectoralis with its movements is innervated more heavily by the upper roots of the brachial plexus versus, or the roots that come from the cervical spine versus the lower ones. But in terms of localization, it's not going to be very helpful to you. Also, what it means is that it's very hard to cause complete weakness of the pectoralis muscle because there's a lot of redundancy. So you won't see people, unless they have kind of a congenital problem. So there's a congenital form of people that don't have a pectoralis muscle. It's actually, then the muscle itself is not developed. But in terms of nerve problems, it's very hard to get weakness of the whole pectoralis muscle. The only thing that I think is useful for the pectoralis muscle is the reflex when it's hyper. When, you know, it's very hard to get a diminished reflex, as I said, because of the redundancy, but when it's hyper, it tells you that there is a kind of a sign of a upper motor neuron problem. So in ALS patients, for example, we check the pectoralis muscle, and that will be a sign of hyper, upper motor neuron problem. MS, for example, can also have that. But I think ALS would be maybe the classic one. All right, so a very important muscle, but not very useful in terms of our localization, but it's good, you know, if someone has a stroke, for example, they'll have difficulty, obviously, moving it. All right, so we talked about so far abduction, we talked about external rotation, we talked a little bit about adduction. The pectoralis is a little bit an adductor, but mainly a flexor of the shoulder. Okay. Now, the next roots, nerves that we're going to talk about come from the posterior cord. Those of you who read Blumenfeld, and I hope it's everybody here except for the PGY2s who have until Thanksgiving. The rest of you should know this by heart. Blumenfeld calls it the cord that's interested in the arts, right? Arts because it has A, axillary, R, radial, which we're not going to talk about this week. And then we have the S, which is the subscapular nerve. We have the upper and lower, but that doesn't matter, just S, subscapular. And then T, which is the thoracodorsal. Actually, I should have said it the other way around. So arts, A-R-T-S, okay? Axillary, radial, thoracodorsal, and subscapular. So those are the nerves that come off the posterior cord. And we'll start with the, actually the last letter of the arts, which is the subscapular, okay? Remember, we had so far several nerves with the word scapular in them, okay? So we had the dorsal scapular, the suprascapular, and now we have a subscapular, sub underneath. Now underneath, don't let it fool you, it's under the scapula, but imagine us being an animal walking on our four limbs, and then this is our torso, then it will be underneath. That's how it's subscapular. When we're standing erect, it's not really sub, it's in front, anterior to the scapular. But this term comes from anatomy of animals, so we kind of inherited that in it, and it's not changed. So the subscapular nerve innervates the subscapularis muscle, which is underneath the scapula. Again, underneath is because the animal is like this, so it's underneath. In a human, it's in front. Okay, I hope I'm not confusing you guys. If anybody finds this confusing, please let me know. I'll repeat it. What is important about the subscapularis muscle is the insertion. The insertion here is in the anterior aspect of the humerus. Okay, so now look at me, and I'll try to show what's going on here. Imagine, so here's my subscapularis, okay? And it's connected here in the inside of the humerus. When it contracts, it pulls inwards. When it contracts, it pulls inwards. Contracts, it will pull inwards. And this is our internal rotation. So before we talked about external rotation, the infraspinatus and the teres minor. Now we're talking about internal rotation, which is the subscapularis because of the insertion here. Okay, so posterior cord. Now we'll go to the T in the arts, which is the thoracodorsal nerve. Thoracodorsal nerve, very, very important nerve. Innervates the latissimus dorsi, the lats. That's one of the bodybuilders' favorite muscles, the lats. And, you know, that's from the time we were birds or bats. It adducts the shoulder. So we talked about earlier on things that put our muscles away, our limb away. This pulls it towards us. It also brings it back. It brings it back from the flexed position. It also brings it back from the abducted position. So very strong pull, okay? So that's this type of movement and also this type of movement. It brings it back to the body. So mainly adduction. We said that the pectoralis earlier, we mentioned adduction, so that's another one that contributes to that movement, but this is a very strong adduction, okay? So if I could fly, well, if I had wings, then the lats are responsible for my ability to fly. So again, posterior cord. So if we have a lesion in the posterior cord, that's the weakness that we'll have, the adduction. Okay. Axillary. So the axillary nerve over here has three components. One of them is, I'm sure you all know, is the motor component that innervates the deltoid. Okay. We mentioned earlier the supraspinatus muscle that is responsible for the beginning of abduction, which is the supraspinatus nerve, supraspinatus muscle innervated by the suprascapular nerve from the upper trunk. Here, what we said is that that initiation of the movement brings the shoulder into a position where the deltoid takes over. The deltoid is a very strong abductor, but it really is, it likes doing it only from the beginning after 30 degrees. So the initial work will be done by the supraspinatus, and then the deltoid will take over. Okay? So that's a posterior cord. So if we have a lesion in the posterior cord, we'll have this atrophy of the deltoid and difficulty with, excuse me, with the abduction. Two other components that are less famous is a sensory component, which is a patch of sensation over here in the shoulder, exactly where you're getting the flu shots. Hopefully some of you already got it. Then that's where, if you feel the pain of the shot, that's through your axillary nerve, okay? So remember that, they get it directly to the axillary nerve. So that's the sensory patch here. And the third component that I promised you that we'll get back to is, remember that we said for the external rotation, the main muscle is the infraspinatus, remember? But we said there's also the teres minor here. You see the mouse here? So the infraspinatus is the main external rotator of the shoulder, but there is this teres minor that helps with this, and that's innervated by branches from the axillary nerve. Okay? So that's kind of important that when you have a lesion in the suprascapular nerve, you will have a little bit of external rotation because of the, if the posterior cord is preserved, by the axillary nerve innervating, branches innervating the teres minor. Okay. Now, a very important thing that as neurologists you should know, and don't fall into this trap. You have a lot of patients, I'm sure you saw by now in clinic, that come in with shoulder weakness, shoulder pain, shoulder problems, movement of the problems with the shoulder, difficulty with movement of the shoulder, and they're sent to a neurologist, okay? Now you know already that the shoulder movements are innervated, first of all, the stabilization of the shoulder, but also the movements of the shoulder is done by different muscles innervated by completely different nerves coming off completely different parts of the brachial plexus. And this is a common mistake of non-neurologists. They think that if there's movement of the shoulder, then it's also anatomically related. We'll see it also in the lower limb when we get to it. For example, movement of the hip. There's nothing related between flexion and extension of the hip, or abduction and adduction. They're completely different muscles and nerves from completely different roots. But a non-neurologist will talk about movements of the hip. The same goes for the shoulder. It's very important that you actually know the breakdown of the muscles and nerves so you're able to identify if it's actually a neurologic problem or an orthopedic problem, which is by far more common in the patients that we see, that are referred to us. That's not even taking into account the patients that we don't see, that are not referred to us because the orthopedics caught them before that, or someone else. So here we have the muscles that are under the group of the rotator cuff. Okay, I'll show you this in a table. And we have here all the muscles that we already mentioned. So we have the supraspinatus from the suprascapular, innervated by the suprascapular nerve. We have the subscapularis muscle innervated by the subscapular nerves coming from the posterior cord. On the other side, we see the infraspinatus over here and the teres minor. The infraspinatus, as we mentioned several times, innervated by the suprascapular nerve, and the teres minor that we mentioned is a branch from the axillary nerve. So what I'm trying to say is that the different movements here, we're talking about, if you look at each muscle, we're talking about the abduction, internal and external rotation. Those are done by completely different muscles from completely different roots, okay? So here we have it in a table. We have the different muscles, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. Remember that they're innervated by different nerves. We have the suprascapular, the axillary, and the subscapular. All right, so why am I confusing you here? So what I'm trying to say is if a patient comes in and they have weakness of those movements, but nothing else, it's really unlikely to be a neurologic problem, right? Because if they truly had a neurologic problem, a nerve problem, then it's hard to explain why there would be such a widespread neurologic deficit pathology, which should hit several components of the brachial plexus. Now you can say, well, maybe they have pathology of the brachial plexus, and there is a disease that you probably saw called Parsonage-Turner or brachial plexitis. But then it wouldn't be isolated just to the shoulder, right? If there is indeed diffuse pathology in the brachial plexus, then it will also involve other muscles that control other movements that come from the brachial plexus, movements that we didn't even mention now, or even movements that are not in the shoulder. So if you have isolated combination of only these movements, and you'll have to go through all the anatomy that we talked about, then typically it's not going to be a neurologic problem. It's more likely a problem in the shoulder. The patients also typically will tell you that they have pain, so it could be like bursitis, inflammation, tendinitis, that you can try to give some non-steroidals. But if it continues, you should probably send them for an MRI to see if there's a rotator cuff tear. And then if they have that, you send them to our orthopedic colleagues, because there's not much we can do and they may need surgery. So it's not a neurologic problem. All right, we're almost done. We need to talk about two more things. So one of the two is the musculocutaneous nerve. The musculocutaneous nerve is a very important nerve that comes off the lateral cord, which, as you remember, is a continuation of the upper trunk. Okay, remember, we're talking here about upper and lower. And then when we're at the more distal aspect, we're talking about lateral and medial. So lateral is a continuation of the upper trunk. So again, if we have pressure on the upper trunk, remember our backpackers who walked all night with 50 kilograms on their shoulder? They may have weakness of the innervated muscles by the suprascapular, but they can also have weakness of the fibers underneath here that go onto the lateral cord, especially the lateral fibers of the lateral cord, which go on to make the musculocutaneous nerve. So in addition to suprascapular weakness, remember the adduction and external rotation, we may have weakness of the musculocutaneous. So what is weakness of the musculocutaneous? I'm sure you all know. The major muscle that you need to remember is the biceps muscle. So we talked earlier about the lats, which bodybuilders like. Biceps, another classic bodybuilder's dream, and that's the musculocutaneous. So it has the muscle component, which is mainly the biceps. So it's flexion of the elbow. Remember, until now, we talked about movements of the shoulder. Okay? Here, there's a muscle that is mainly important for movement of the elbow, but it still comes off the brachial plexus, although the distal part of the brachial plexus, so it's worth mentioning in this talk. And then it has also a sensory component, which is the lateral cutaneous nerve of the forearm, or another term is antebrachial. You'll hear these terms interchangeably. So antebrachial is forearm in English. We have the brachial and antebrachial, or arm and forearm. In this case, it's the antebrachial cutaneous nerve, the lateral. So this is in the forearm sensation. So if we have a lesion, a very severe compression of the upper trunk here, we'll have weakness of the muscles from the upper trunk, the infraspinatus and supraspinatus, as well as musculocutaneous. So that's a classic upper trunk weakness. Okay. The last thing that I want to talk about today is these two sensory branches that come off the medial cord. And those are the medial cutaneous nerve of the forearm and the arm, or as we mentioned, the brachial and antebrachial sensation. So this area here. Now, as you know, a lot of people think of this area here, the medial aspect of the arm, as ulnar, is an ulnar distribution. And you know, as neurologists, that that's not true. Next week, when we talk about the ulnar nerve, we'll see that the ulnar nerve is responsible for actually sensation only from the wrist joint and distally, and even that, not all the hand. We'll talk about it next week. But the sensation of the medial aspect of the arm and the forearm has nothing to do with the ulnar nerve. Yes, if you have ulnar neuropathy, you may have shooting pain along this pathway, right? When we hit our funny bone, it hurts here. That's not what I'm saying. What I'm saying is when you do your pinprick exam and you find true sensory loss, and you find true sensory loss in the medial aspect of the arm here or the forearm, don't think that it's an ulnar neuropathy. Now, you may think that what I'm telling you here is just semantics, and it's not. It's actually very, very important, because ulnar neuropathy, you know, it's a dime a dozen. We see it every day. Yaakov and I and Paul and Nuri, we see those a lot in the EMG lab. A dime a dozen. Ulnar neuropathy is very common. It's self-limited. A lot of times goes away on its own. There's also surgery. We'll talk about that. But if you have true sensory loss here because of nerve dysfunction, then that's actually a very big red flag, because that could tell you that there's a problem in the medial cord, which is a continuation of the lower trunk. Okay? The lower trunk. So if you have a lesion here in the lower trunk compressing the bottom part here upwards, the nerve fibers which are medial, which are the lowest fibers in the lower trunk, which become the fibers, the medial fibers in the medial cord, which will become those two sensory nerves, will be impaired. So lesions over here are never good. Okay? And a lot of times they have to do with cancer. It could be remote cancer with lymphadenopathy, like breast cancer, or it could be that we have a Pankos tumor, so a tumor in the apex of the lung, pushing from below upwards, and the only thing that the patient will have, no weakness, nothing, just the sensory loss in the medial aspect of the arm. So don't confuse, you know, cancer with an ulnar neuropathy. You don't want that to happen to you. So again, here is how it looks like. So those are the areas of the medial arm and forearm. Okay. So next time we'll talk about the nerves. Any questions? All right, please walk around with the aids to the neuro exam. Every patient, you should actually go through it. The only way of learning it and for it to become automatic to you is actually practice, practice, practice. And, you know, when you see the patient, document to yourself where was the weakness. Maybe you won't remember in the bedside what does what, but document it and then go to the workroom and then open the book and just build up the scenario, and you'll come up with where is the pathology. But you have to practice that, otherwise it's hard. It's hard to remember without practicing and understanding. All right, if there's no questions, then have a very nice rest of the day.
Thank you, Doctor.